we will get started here momentarily. Good to have everybody back with us. Going to have a minute to let people get in and settled in. And let me just quickly scroll through. You'll remember all our hub team members. We're missing Vonette Fay today. She is on vacation, but we have everybody else with us on the hub team. And I'm Catherine Piers. And we have June Sadowski, Kathy Bishop, Lucy Ezralou, Seth Keller, Cameron Jeter with us. And we are recording this. So just be aware that we are recording this. And you are all muted by default, so you don't need to think about doing that. If we have questions, and I will say, please feel free to put your questions into the Q&A box at any point. And also, please, in the chat box, would you put your name and your organization so we know who is with us today? That would be great. And we will, I think, pretty much go ahead and get started here in just a minute. If you do want to speak, maybe you've got a question at some point and you want to be unmuted and speak, you can raise your hand. That little hand signal is down there on your controls. And so again, if you put your name and your organization into the chat box so we know who's here, that would be fabulous. And with that, I am going to go ahead and stop my screen sharing and turn this over to our intrepid facilitator here, Cameron Jeter. And Lucy, I will give you the controls if you don't already have them, but you should have them.
Welcome, everyone. It really is a delight to be together again. I've been contemplating how, as Project ECHO teams continue their relationship over time, we become comrades in the same cause, even a family, that for the state of Texas, that we seek to collaboratively learn together and teach together about ways that we can help our fellow loved ones and clients with intellectual and developmental disabilities who are either at risk of having dementia or have been diagnosed with dementia, and whether that diagnosis was accurate or not. We welcome all of you. Many have joined us in previous months, but for those of us who are new to Project ECHO, I briefly will describe what our model is. Project ECHO are similar to webinars, but are different in that maybe just the first 20 to 30 minutes of our hour and a half is that didactic lecture from an expert. And then as we move on to the bulk of our hour and a half together, it's an anonymized case study presented for the topic of the Project ECHO, which again for us is those with IDD at risk for or who already have dementia. But if you're interested in other Project ECHO topics, feel free to visit the Project ECHO website that has hosted clinical topics ranging from cancer to, like us, IDD and dementia, hosted across countries internationally. And so we do encourage you, as you think of comments and questions, feel free to type those into the chat box or the Q&A tab on the panel that you see at the bottom. And I'll now transition to tell you what we planned for today. We're going to be hearing from Dr. Lucy Ezralou, both for our initial didactic session and on to the case study. And so today, Dr. Ezralou, who is a neuropsychologist by training, is going to be discussing with us, is it really dementia or is it depression? And how might we distinguish between these two that can manifest with similar symptomologies? Once she's presented to us the didactic information, we'll pause for some questions and comments and discussion if we have them, and then move on to the case study. So thank you, Dr. Ezralou, for being with us, and we look forward to learning from you.
Good morning, everybody. And give me a minute as I transition to my PowerPoint and just make sure that I'm able to do this in a way that you may be able to see it. Okay. So do you see the full screen at this point in time? Very
Yeah.
good. Okay. Thank you. So I'm going to add that, is it dementia, is it depression, or is it both? So that's the other thing that I'm going to put out there as a consideration. So during our didactic today, these are the things I want to touch upon. I'd like to review what we know about major depressive disorder and apply it to adults with intellectual and developmental disabilities, and compare in a ways that make sense major depression and dementia, in particular Alzheimer's disease, and consider differential diagnostic questions. Are observed changes in functioning due to depression or dementia, or are observed changes due to depression that is co-occurring with dementia? So just a few things about depression and aging. And I actually want to frame it in a certain way. I think most of us think we know what we're talking about when we say depression. But I want to emphasize that this morning, or heading into this afternoon, I am not talking about depression in a small d way. I'm talking about it in a big D way, which means major depressive disorder, a clinical condition that is rather significant. And we will go through the criteria for the diagnosis of major depressive disorder. But depression is a very interesting phenomenon because it can occur with other psychiatric conditions. So you could have, you meet criteria for schizophrenia and have depression. You can, certainly in bipolar disorder, you have phases of depression. And anxiety is often a traveling companion with depression. So you see depression kind of occur as a lot of features in other situations. I'm talking about major depressive disorder when somebody is meeting criteria for that as a distinct condition. So having given you those kind of ways of thinking about it, let's consider that although adults with IDD are at high risk for depression as they age, depression is not a normal part of aging. And some people who might benefit from getting treatment don't necessarily come forward for it because they're ashamed to admit they're depressed, and they see it as a sign of weakness or a character flaw. Older adults with IDD and without IDD tend to report physical symptoms of depression, such as problems with sleep and loss of appetite, more so than younger adults with depression. And so sometimes an individual is presenting to their primary care physician with what appears to be physical signs and symptoms of a medical condition, which actually are not supported by any findings, medical findings. And so that's just an interesting phenomenon to think about. And certainly, we saw this particularly during COVID, but when adults, particularly older adults, lose their social supports and become more isolated, they are less likely to independently seek help for their depression, even if they might benefit from it. But the key point of this slide that I want you to take home with you is that depression is a very treatable medical condition. And so if we identify that, it makes sense for us to aggressively go after it. I'm having a hard time moving my cursor here. Okay. So I want to just talk about the medical condition of depression as it is defined, or as it is the criteria identified in the DSM-5, which is the latest version of the diagnostic manual, statistical manual that is used for mental health diagnoses. And you'll see that it's not just sadness. There are a number of areas that are disturbed when an individual has major depression, and a acronym that is used is SIGI-CAPS. Sleep is disturbed. Individuals who may have been interested in certain activities now are no longer interested in pursuing it. Individuals may express feelings of guilt or low self-esteem. You see changes in energy with low energy and fatigue, very likely. Concentration may be poor. It may indeed add to forgetfulness. Appetite changes may be obvious. There may be changes in just motor movement, agitation or slowing down, or what we call psychomotor retardation. And suicide, in other words, thinking about ending one's life. So these are areas that one might observe if somebody presents. And by the way, one of the considerations that I want you to have in mind for individuals who indeed present for any kind of consultation is, does the person have a history of depression? Are they coming into their aging with a history, or is that unique to what is going on with them more recently? And if that latter is the case, we might be thinking it might not be depression per se. So again, major depression, the characteristics are sustained disturbance in emotion, cognition, or behavior. So notice that thinking ability is affected, behavior is affected. It's not just sadness. And this can all lead to significant functional impairment and an overall reduced capacity for pleasure and enjoyment. So again, another way of looking at some of the key features of major depressive disorder: sad or depressed mood most of the time, sleep disturbance, loss of interest, motivation, withdrawing socially from others, self-isolating. We talked about guilt, a sense of worthlessness, fatigue, diminished ability to think or concentrate, changes in appetite, and that would lead to either weight loss or weight gain, restlessness or lethargy, and thoughts of suicide, feelings of hopelessness and or helplessness. Now, obviously, any one person does not exhibit all these signs, but these are among the signs that are considered. So as you're thinking about people whom you support, notice that some of these criteria overlap with what we commonly think of as signs of dementia. So severe depression can cause changes in a person's ability to think, to concentrate, to make decisions. It can affect their judgment and their behavior. And we've said that it can affect appetite and sleep, or vegetative signs, as we sometimes refer to that. It can affect people's motivation, their interest in people and activities. So you'll see a marked change in just engagement with others and with one's surroundings. And the person who's very depressed may appear listless, lethargic, out of it, slow to respond, or unresponsive and inactive. So notice here how that could really appear somewhat like somebody who is exhibiting signs of a dementia. So for adults with IDD, depressive symptoms often appear as behavioral changes. So, again, what we're after here, and this morning, at least in how we're considering it, if we've observed the changes in how a person's functioning, to what extent might that be attributable to depression? To what extent might that be attributable to dementia, or a combination of depression and dementia? Because look, you can have a loss of adaptive living skills, right? So that is one of the key things we think about with dementia. So if this wasn't complicated enough, just to further complicate matters, depression often co-occurs with Alzheimer's disease and dementia of the Lewy bodies, Lewy body dementia. When this is the case, that depression is present, whether or not there is also a dementia at play. Prompt treatment of depression may preserve the person's functioning for a longer period of time, even though they may be on a downhill course, given the progressive nature of dementia. So the following symptoms can be seen in both depression and Alzheimer's dementia. Again, loss of adaptive skills, disruption in sleep cycle, and appetite changes. These are all things you can see in either depression, major depressive disorder, and or in dementia. So again, let's revisit major depression. It is a disorder of mood. It is called an affective disorder to signify that key aspects involve disturbance of emotion or feelings. And it depends upon the presence of at least two main symptoms: persistent and pervasive low mood and loss of interest or pleasure in usual activities. Now, many people feel depressed or sad, let's say, at small d, at various periods of time, but it's not considered clinically significant unless it begins to interfere with normal activities and persists for at least 2 weeks, in which the case of a diagnosis of depressive illness or disorder may be made. So interestingly enough, many people who are depressed are not necessarily in the corner crying, bulled up, upset. They may be apathetic. So you might not see somebody weeping when they're depressed or, agitated when they're depressed. You may notice that they're apathetic, okay? And apathy, depression is cited as most common, affective symptom in Alzheimer's disease, one of the most common affective symptoms in Alzheimer's disease. Depression is frequently present in Alzheimer's disease, but is more persistent in Lewy body dementia. And these symptoms of depression in either Alzheimer's disease or Lewy body dementia are associated with greater cognitive decline. So if a person has Alzheimer's disease or Lewy body dementia and depression, they are more likely to have a steeper cognitive decline. And in fact, with Alzheimer's disease, we've seen in repeated studies that it is actually associated, having a major depression along with Alzheimer's disease is associated with a lower survival rate over a 3-year period. So it has implications for the person's, mortality. Major depressive symptoms can include fatigue or exhaustion, the appearance of sadness, which sometimes is described as a loss of liveliness, humor, and spontaneity, loss of concentration or task completion. Now, again, these are things that we might note in terms of people with dementia. Irritability and moodiness, increase in aggressive verbal behaviors, agitation, sleep disturbance, weight loss, self-absorption, inattentiveness to people and surroundings. So a general kind of turning in and withdrawal and a lack of interest in participation in all or most activities, given that the person was previously participatory in those activities. What do we mean by psychomotor retardation? We mean a general slowing down in all areas, as well as an extreme slowdown in self-care activities, such as personal hygiene, dressing, and eating. Individuals may report they are fearful in public places or among strangers, and there may be some increases if the person had previously shown compulsive or ritualistic behaviors. We may see an increase or an uptick of this when they meet criteria for major depressive disorder. And extreme sleep problems are possible, including severe insomnia, reversing of day and night sleep patterns, and that should ring a bell because that also happens in dementia, and nocturnal activities such as roaming the house, which, again, should remind you of some of the things that we've been alerted to about individuals who may have dementia. So unlike some of the other significant psychiatric illnesses like schizophrenia and bipolar disorder or schizoaffective disorder, major depression can actually occur at any age. So that is why it is interesting to note whether the person that you're supporting has a history of major depression or seems to be aging into it. Late life depression is often overlooked or inadequately treated. And as we have said, major depression can in and of itself increase cognitive decline, and certainly can increase cognitive decline in the context of dementia. So some key distinctions between depression and dementia. Depression tends to show an up and down pattern of decline. That is, with time and treatment, the person will show some improvement and eventually return to pre-morbid levels of functioning. And I should add the caveat, often, not always, return to pre-morbid level of functioning. Symptoms of Alzheimer's disease tend to fluctuate in the early stages, but over time, it shows a more progressive and non-reversible pattern of decline. And here we have a chart, I don't know if you can read it, that compares depression and dementia along certain lines. So onset of depression tends to be rapid or slow. It could be either one. But with dementia, we know it is progressive and it tends to develop over several years. The cause for depression is alterations in neurotransmitter function, and in dementia, it's progressive brain damage. The duration for depression is months and can be chronic. I mean, there are people who are what we call dysthymic, in which they are always operating at a low level of depression. But normally, or not, but usually, depression will resolve, even if the person does not get treatment, usually resolves in about 6 months. But dementia, the duration of years to decades, and there's no resolution of it. Courses usually recover within months. It can be relapsing. And again, dementia is non-reversible and ultimately fatal because we're talking about brain function failure. A level of consciousness in depression, normal or slowed, and a level of consciousness in dementia is usually normal. Orientation is usually intact in depression, and dementia, correct in mild cases, first loses orientation to time, then place and person. Thinking for somebody who's depressed tends to be cognitively distorted, tend to be negative and pessimistic. And dementia, it's less about negative thinking and more about impaired thinking or impoverished thinking. Attention for people with dementia tends to be difficulty with concentration, and attention, at least in the beginning phases of dementia, are usually overall intact. Awareness is diminished in depression, and in dementia, can be alert during portions of the day and may even be hyper alert. And in terms of sleep-wake cycle, there tends to be either oversleeping. You have people who sleep extensively during the day, don't get out of bed, or have difficulty sleeping. And dementia doesn't necessarily, in the beginning of dementia, it's not necessarily disrupted. It's later on that sleep-wake cycle is disrupted. And here's yet another way of looking at it. Again, here we have dementia listed on the left, depression on the right. So I just want to take your attention to the bottom part of this. So with mood in dementia, depression may be present in early dementia. And in depression, of course, depressed mood, lack of interest or pleasure in usual activities, and change in appetite, either increase or decrease. Thinking in dementia, difficulty with word finding and abstraction. In depression, thinking tends to be intact, but there are themes of helplessness and hopelessness present. That's that negative thinking that I was referring to earlier. Perceptions in dementia, misperceptions are usually absent in the beginning, at least, of dementia. It can be present in Lewy body dementia from the beginning. In depression, perception is usually intact unless somebody has major depression with psychotic features, which is a severe form of major depression, in which case they may have hallucinations and delusions associated with that form of major depression. So decline in mental function tends to be more rapid with depression than with Alzheimer's or another type of dementia. Unlike people with Alzheimer's, people with depression are usually not disoriented. People with depression have difficulty concentrating, whereas those affected by Alzheimer's in particular have problems with short-term memory. Writing, speaking, and motor skills are usually not affected in depression, whereas they would be in dementia. Depressed people are more likely to notice and comment on their memory problems, while those with Alzheimer's may appear somewhat indifferent to those or unaware of those types of changes. So possible causes of depression in those with dementia. Depression has been associated with an increased risk of dementia, but the mechanisms that underlie this association are actually not well understood. There have been several possibilities that have been proposed. One possibility is that if the person has no history of depression and appears to have depression later in life, depression may actually be a prodrome of dementia. In other words, it may be a harbinger or what precedes dementia and have more to do with changes in brain changes that are first evident as depression and then become evident as dementia. It may be that if you are depressed, it reduces your threshold for developing dementia. And it may be that depression leads to damages to neural systems, particularly the hippocampus, which contribute to the development of dementia. These are some of the possible associations that have been proposed. Past or lifetime history of depression is known to increase the risk of developing both Alzheimer's disease and vascular dementia. Vascular factors may play a role in depression and dementia. Cerebral vascular disease, hypertension, diabetes, and other vascular factors may cause both cognitive impairment and depression. So just a word about grief, because actually as people are aging with IDD and possibly aging into dementia, there are a number of losses that they are experiencing, and grief, like depression, can cause physical symptoms, and it certainly can cause psychological symptoms, and these issues can lead to a number of problems. So grief is often associated with many losses, such as loss of physical strength and abilities, increased confusion, loss of work, changes in housing or aging as an individual kind of ages into dementia. These are the changes they may experience and respond to with a form of depression that we would link with grief. Loss of one's self-sufficiency, loss of privacy and self-esteem, changes in social contacts and roles, all may be precipitants to grief or some form of depression. So we also know that there are neuropsychiatric symptoms of dementia. We know that people with Alzheimer's disease can develop NPS, neuropsychiatric symptoms, during the process, and it actually can be considered a key component of Alzheimer's disease. They may be present at any stage of disease and can include depression. In those with Alzheimer's disease, the severity of NPS or neuropsychiatric symptoms is associated with increased cognitive decline, worsening general health, and increase in mortality. And additionally, neuropsychiatric symptoms like depression can occur in individuals with mild cognitive impairment. It can be a presenting symptom of dementia, and researchers have developed the concept of mild behavioral impairment, MBI, to address this phenomenon, which could occur at any point from normal cognition through to mild cognitive impairment and dementia. And it's characterized by late life onset of persistent symptoms of depression. So late life depression, higher likelihood of cognitive dysfunction. So while the conventional wisdom, I know when I entered the field, we thought, well, okay, pseudo-dementia is depression that is masking as dementia. And if we treat the depression, then the person will return to their previous level of functioning. But current research reflects a rather more nuanced story. In recent research, it was shown that while 53% of depressed individuals do show improvement in their cognitive symptoms once they improve in their depression, another 33% have what we would term irreversible dementia. In other words, they don't return to baseline functioning, even though their depression is considered to have been successfully treated. So there's a significant variation in late life depression in terms of causes. While depression in dementias have been consistently tied to greater cognitive decline than those without depression, this pattern may not hold for conversion rates from mild cognitive impairment to dementia in those without depression. So we're not, jury is out for those people with mild cognitive impairment. We don't know whether having depression or not having depression really applies to whether they go on to develop a full dementia. So again, here are some of the range of medications that you may be familiar with. People you support may be on: Celexa, Lexapro, Paxil, Prozac, Zoloft. And again, this is not the definitive list, but some of the more common antidepressants. And then there's psychosocial interventions. Depression usually responds to treatment with psychosocial depression and medication. So really the thinking in the field is the combination of both are what's indicated. So what are the things that we might do to support person who has major depression? Engage the individual in preferred activities, schedule pleasurable activities, encourage socialization, get the person to be as active as tolerated. Inactivity is associated with continuing depression. Promote exercise as tolerated, provide positive feedback and opportunities for supportive counseling if the individual has the language skills that support that activity. So some take-home messages. So you may have, I don't know if I helped you differentiate major depression from dementia or not, but I hope that I provided considerations for why it is complex and difficult to differentiate major depression from dementia. Always we consider, how does the individual we support enter into their aging? Do they have a history of depression? If so, we certainly want to make sure that they get all the treatment that they can benefit from. And we would also consider, have there been any recent psychosocial changes that might explain late onset of depression? Or does this person who has no history, no apparent psychosocial stressors that might explain late onset depression, might this depression that is being observed be prodromal or a harbinger of brain changes associated with dementia? So again, depression can co-occur with dementia. Depression can be a feature of other psychiatric disorders. So I would say that you assess for and treat depression whenever it is suspected, regardless of whether the person may have dementia, because we can treat depression. And treatment can consist of pharmacological and non-medical psychosocial supports and interventions. So here are some references. And I am going to, at this point, and stop and see if there are any questions, concerns, or words for the day on the basis of my presentation.
Thank you, Dr. Ezerlou. At her invitation, I welcome Hub team members and those of us at spoke sites across Texas to ask questions or weigh in. Yes, Dr. Keller.
Thank you very much, Karen. Lucy, that was great. I turned my screen off and I was just listening wholeheartedly. I'm a neurologist for, the Hub people know who I am, and maybe some of the spokes know that. And this is it's such a wonderful, important topic to talk about because the comorbid or a combination of issues that we do see in depression and people with dementia. And it's really great, Lucy, that you took such a deep dive in this issue. And really, so one of my comments was thank you very much for all the information. And I just want to bring out some issues that I see and maybe in a little conversation to help about it. First of all, you certainly did talk about anxiety in some respect. So if you could just give a comment about, I mean, I know this is mainly about depression, but what's your sense about anxiety plus depression and how that plays into all this conversation?
Well, I mean, anxiety is, as I may have mentioned, a frequent traveling companion to
Yeah, traveling.
depression. So, it is very common to see both, or you can see somebody that has an agitated depression, where it is depression, major depression is their main diagnosis, so to speak, but there is a kind of irritable, agitated, restless quality to it that we sometimes think about as anxiety. And I think, certainly as somebody's skill set may erode if they do have dementia, that will kind of fuel additional anxiety. Can fuel depression, can fuel anxiety as a person becomes a little bit more overwhelmed. Their coping resources that they may have had may be less available to them, right? As they begin to experience increasing impairment. So I see this as a big problem. I mean, we talk about behavior and psychological symptoms of dementia, which is very common both among the general population, and we have every reason to believe that it's common among people with IDD. And so you do see anxiety, depression, and other psychological issues that kind of flame up and interfere with functioning, because the more anxious and depressed you are, the less able you are to access what remaining cognitive reserve you may have.
Right. And the one comment I'll just make, and is that in the beginning, that I do see many people that I treat with dementia is the concomitant nature that they do have anxiety and depression that are kind of in the beginning, cause and effect and all that. And the one thing I think about it, and again, not to pull it out of each of you, my dear friends and colleagues on our hub team, is if you could imagine yourself, if that in your daily life you're having some cognitive problems, you're not thinking right, your memory's not good, and you do have the insight, you do see it, how would that emotionally make you feel? You don't have to answer that question. I can answer that myself. So if you yourself knew you're having a problem, whether you're in denial, you accept it or not, I think there I see some cause and effect, how you emotionally may react. So I think of some of the emotional things that I see are either depressed, they're upset, they're frustrated, they're worried. I see that as a reactive kind of situation sometimes to what cognitively might be going on, whether it's normal or not.
Yeah.
Yeah,
Agreed.
thank you.
Mhm.
Dr. Ezralou, I think you did see the question in the chat box, which is if you were to try a medication for a client, how long would you give it to see whether it's working or not?
Well, medication is not my wheelhouse, so I will defer to the physician on the team. But I also want to say that it's very hard. I mean, medication is very individualized in terms of response. So I don't know. Dr. Keller, did you want to?
Oh, absolutely. That's a great question. I'm actually glad you asked that question because basically, I totally agree that it should be treated. And I guess the decision of treating it, it should be aggressively treated on how bad it is. So not every depression has to be treated, but if it's severe enough, interfering with life and danger and have you, it absolutely should be treated because it can be reversible. And this is where it gets, you have to, so for me as a physician that does treat depression every day, I have a favorite. like I have my favorite antidepressants. I start low, and usually I give it about like 3 weeks or a month at a low dosage, just say Zoloft, which is sertraline, which is called an SSRI. That's the chemical nature of it. I then go up from 25 to 50 milligrams to maybe 100 milligrams. But one thing that's very important about it is even if the person doesn't respond to the treatment, doesn't mean they're not depressed. It might be only that the medication that I'm prescribing isn't the right medication. So therefore, I might go from one medication to another medication. If it becomes more challenging than that, then often I might refer to a primary psychiatric practitioner who might be so-called smarter or better than I am. So a lack of response, I'll say it again, lack of response to an antidepressant doesn't mean they're not depressed.
What would you do for a client who is resistant to take the medication that is prescribed and recommended?
I mean, I can let my other friends answer that if they want to answer that. I don't want to take all the oxygen in the room on this conversation, so I'll kind of defer that. I don't know if anyone else has a comment. I certainly can comment on that too. So I don't know if Kathy
Yeah,
Bishop.
so
Catherine,
I just, you know,
Louise.
before I do want Dr. Bishop
Yeah.
to be able to, but I just want to comment that, you know, again, psychosocial intervention is another way of thinking about it. So not everybody, and this is true in the general population, not everyone who might be a candidate for medication decides to take medication. Doesn't work for everybody. I mean, there is a portion of the population that, you know, even though probably antidepressants are among the more successful kinds of medications that we have, most effective, they don't respond in the way that we think that they might, or they may be, you know, medication is not going to work for them. But there are things in the environment and there are psychosocial interventions that can be looked to as ways of supporting as well. So with that, be quiet. Sorry, Dr. Bishop.
Is Dr. Bishop, help us answer this question and then make the remarks for which you raised your digital hand.
Well, the digital hand is kind of related to this whole discussion anyway that's been going on. And my educated suspicion is that depression continues for many people throughout the course of the disease, even to the point where they're not responding to the physical environment, to interaction with others, and that there's probably some component of depression. The other issue is the medications related to dementias, to other secondary conditions in dementia. Also, a major side effect can often be depression. And so there's the complexity of all of that. And so I guess thinking once someone started and we think it's helped a little bit, at least made the person calm and able to interact with others. Should that be, and that's the question I'm going to throw out, and then I'll answer the other question. Should then we continue that medication for the depression over the course of the disease and the life? And if so, is there a point we might want to reduce the amount? I mean, how do we want to monitor to try to get the best? So I'm going to leave that for a second open for the medication experts. I think there are major things you can do in the physical environment in particular, especially as we get into middle and end stages of the disease. And so we always want to keep people engaged with their environment and engaged with others. And we find ways to do that. It's important we know the life story. We know the essence. We know that the music that person responded to, rhythms that were important earlier in life, the sense of touch and tactile, smells in the environment that are positive smells that help support the person, making sure we're cooking and baking. I'm thinking of a person in one of the other echoes I'm on who was at end stages, was mostly in bed with lifting and moving and sometimes moving to other positions, and had help during the day while the sister worked. And the sister came home at night. There was no more help and the sister wasn't getting sleep day after day. And so we helped her set up a sensory on the ceiling in ways that the individual could, she could press a button to make things happen. And at least for a number of months, we haven't heard feedback since. That made a world of difference, along with changing the schedule for the workers to make sure that there were people there who could make sure that the sister was getting time so she could do the important work. And so they're able to increase some of those hours. So always looking to the physical environment, think about what makes you feel comfortable, happy, safe. Think about what it feels to be lost in space and lost in yourself, and to find ways to help return that person to who they've been. For me, for example, I've been a teddy bear collector for years and years and a seller of them. And Catherine sent a wonderful photo the other day of a chair that was just loaded with, it was actually designed with teddy bears. And it really makes you think about, for the person that would be comfortable and respond to that, what a soothing place. And if you spend a lot of time sitting still with that wrapped around you, maybe even a blanket with a teddy bear on, or being able to hold a teddy bear, which is the opposite of what we allow in the field of IDD, because we say that's not normal. And so looking how we can set up that comfortable, sensory-rich environment to meet the needs of that person, to make it feel like a place of comfort and safety. Sorry, too long.
No, but I'm sitting here smiling, thinking of sitting with teddy bears, so thank you. Catherine, we'd love to hear from you.
Yeah, I should send that picture out to people. It was a chair that had actually been upholstered in teddy bears. And so it was really, really cute. I think I saved it on my phone. I'll have to send it out because it was really worth it. I'm a stuffed animal lover too. And as soon as I saw it, it caught my eye. I just wanted to pick up on a couple of things Seth said, and Kathy kind of covered them, so I'll make it brief. But one is that I think reinforcing that notion that these medications don't work like a magic bullet is important. I don't think the medical community does a good job always of explaining to people how these medications work, and that they take time. You're not going to see an overnight response to it, and it can take weeks, oftentimes. And so I just wanted to reinforce that, you know, just because you don't see, and sometimes, you know, with some of these medications, it can almost increase agitation, anxiety, and depression before it gets better. I have a family member who takes these medications, and when he's been started on a new one or a change in dosage, it can, you know, he can look a little worse before he looks a little bit better. And again, I don't think we always do a very good job explaining these sorts of things to family members as to what to expect during that period of time. The only other thing I wanted to mention is, you know, we're talking about depression, but one of the things that I see, and I suspect the rest of you do frequently, is anxiety. And oftentimes I hear people saying, oh, this individual with dementia is really angry. And anger oftentimes is a manifestation of anxiety, as well as can be depression. And so just another symptom that anecdotally I've run into, and particularly I think in men, that's just, again, that's an anecdotal observation on my part, but that depression in men I've seen oftentimes kind of show as anger. And so just those couple of things, and I will lower my hand.
Can I add a few more comments after that, react to that, if that's okay? Yeah, and I think you all bring up, this is such a rich conversation. And I'm going to go to one thing, Catherine, that you just said about these symptoms that occur after a treatment. And I'll go back to what Lucy said about psychomotor retardation, which is basically slowing or no energy in some respect. So this is really the truth of it. So if you give an antidepressant for someone that's already, like, I'd say slug, that's really not right for me to say that word, but if you're very slow, you have no low energy, you then give them an antidepressant, now they have energy, there's a risk of suicidality. So there's a risk of getting having the person commit suicide because now the energy they never had before, now the energy, and they could commit suicide. So there's a risk of antidepressants that can be associated with causing suicide. So that's really true. The other part about with medication is how do you determine the benefit? What's the way of measuring? Just like we talk about, how do you measure the effect of dementia, the symptoms of dementia? It's subjective. So how does one really measure whether or not someone's not only depressed, but they're getting a reaction or response to the antidepressant medication? And how do you know it's adequate enough? And how do you say they're good? And I'm saying this in somewhat of a rhetorical way, because you might get, as we kind of alluded to, a partial response. So if you get a partial response, is that good enough? And this is like a judgment call. So we, as the practitioners, we as the people, the caregivers, the observers of families, we're often observing this from where our seats are, or sitting with them, or loving them, or caring for them. We're often observing them, even though the individual, obviously, if they are able to, can speak for themselves. But we're often, us caregivers who are often reporting this to the healthcare provider, we're actually giving them back to the doctor. Oh, doctor, this is what I believe they're responding to. This is how I think they're acting. So you also have to, not only you're treating the person, but it's also the caregiver. So you have to explain to the caregiver exactly what you're treating, what they're looking out for, because they're the ones who often are going to give you the feedback that I'm then going to use to know whether the treatment's so-called effective or not. Because they live with them, they care for them. So you have to also make sure that the caregiver themselves are savvy. They have to be savvy people to understand these things. Otherwise, if they don't know them or understand it, you're going to get, me as a provider, I'm going to get a whole misperception of what I think I'm getting out of the treatment when it may not be accurate.
Thank you. Dr. Ezralu, please.
Yeah, I just wanted to follow up on two things that Dr. Keller just said, and what Catherine had said about this idea of anger, or maybe irritability and reactivity that you see. So you can see that in depression, you can see that in anxiety, you can see that in dementia. So, it is this kind of reactivity, there's no kind of delay in response, whereas the person may have previously been able to kind of think it through in a different way, or had a coping skill or whatever. There's more of just kind of an immediacy and a heightened irritability, reactivity to things. So that's one thing. And then what Dr. Keller was saying about, so it's a well-known fact that people at a higher risk for committing suicide following treatment for depression. So that seems counterintuitive. You think, well, they're treated for depression, so why would there be a heightened risk? And it's precisely because the person now has energy and, to follow through with the possibility. So it's not necessarily that the medication is causing that. It's that the medication is now giving them an opportunity. So the thinking about hurting oneself preceded the medication and was part of that. But, for instance, people are at highest risk for suicide following inpatient hospitalization for major depression. So, so it just seems that one of the things that teams can take away from that is just increasing monitoring, making sure there's really a good risk assessment for anybody who may meet criteria for major depression. So it may be that they didn't have the means or the energy to follow through, but once they are treated for depression, they are a little more focused on that. So that's just, I just wanted to nuance that a little bit more. Mm-hmm.
Thank you. We'll hear from Catherine, and then I think we'll move on to the latter half of our Project ECHO itinerary, which is the case presentation.
There we go. Thanks. Just one question popped into my head because people ask it every now and then, and that is the use of CBD or other substances like that for treating depression and behaviors of dementia. Wondering team members' insights, thoughts, experiences even with that, because it does come up with some frequency.
Yes,
Can
Dr.
I
Keller.
respond? Yeah, I'm actually a medicinal marijuana prescriber in the state of New Jersey. So I have a license in New Jersey to prescribe it. And I prescribe it specifically as a neurologist for sleep problems, pain difficulties. I treat a lot of seizures, so I treat it for that. The pain and the issue of exactly mood and how it affects someone's mood is definitely a common conversation. And think about what is medicinal marijuana? What is marijuana? What is CBD? What is THC? And I think it's important to appreciate it because what that will help answer some of that question is what do you get out of it? So the CBD is the calming, relaxing, help with sleep variety of medicinal marijuana. The marijuana is always a percentages of different component parts of out of the plant. It's not all pure one thing or the other. And even the pure CBD, it can be pure CBD, but when we're talking about just medicinal marijuana, it's percentages of a little bit of THC, a little bit of CBD, and some other ingredients also. So medicinal marijuana, you have to understand. So CBD is really more the calming, relaxing variety that really it can. I mean, I do believe that in the right people that it can relax people and calm them down, and I feel it's very safe. However, the THC is the up variety. That's like the more potent, you can call it potent. That's the high. It gives you that exhilaration or that high feeling that people get, and that may not be so good. That may not be good for people with different behaviors. So again, it really depends on what it is they're getting. And I'll try to make a funny comment. I don't know the laws in Texas, but what is the law in Texas? Is it recreational? Is it all medicinal? What is the law in Texas? Forgetting it.
Dr. Sadowski.
No recreational, but medicinal.
Okay, so let me kind of give you a funny comment. Again, I got to watch what I say. I don't really know all the things in Texas, but typically, and I work with dispensaries. These are people that are medical dispensaries, and I can give you a general sense about it. I might be wrong about Texas, but typically, when I prescribe medicinal marijuana for anything and everything I do, all I'm doing is I'm giving them the legal ability to go to the dispensary and then talk to the people internally in the dispensary who are the quote unquote experts. They're the ones who basically are the ones who kind of turn behind, pull out of the back of them and say, oh, here's this and here's this and here's this. And so it goes to the question, and I'll maybe leave it at this: who are they? Who are these experts that they're going to? Are they PhDs? Are they professorial? Have they had times? And I see Lucy's laughing here. So basically, they're probably people that are getting stoned all the time. I mean, I hate to say this, but I'm just saying they might be people. I mean, I hate to be facetious on this this very professional echo that we're doing. So again, who are they, and are they really that expertise and knowledgeable that they have all the experience and all that? So number one, what are they getting? And who's the one that's giving them the guidance?
Well, I mean, that is a certain kind of expertise, right?
Yeah, right, exactly. That's a good point.
Right, what do they say? The 10,000 hours of practicing and experience.
I need more time. I gotta smoke some more, then I'll really get this thing.
Right. Well, let's turn it over to Dr. Ezralu, who will present her case. We've got 30 minutes remaining together, so please.
All right, so let me know, can you see this slide, the full screen? Good, good, good. All right, so I'm going to present the case, and I want you to know that this person who is actually an amalgam of several different people that I have seen. And so this individual was presented, I'm presenting to you as known as having intellectual developmental disability and has been previously diagnosed with mild cognitive impairment. So this is the case of Mr. A. He's a 55-year-old man. He is fairly high functioning. He has mild intellectual disability. He does live in a group home. And he presented for consultation with the following symptoms. He had had weight loss. He was reported to be self-absorbed, energy very low, exhausted, even reported that he was exhausted a good deal of the time. He had been previously known to be fairly social, and he was now socially withdrawn and had a difficulty with concentration. So that both his staff and family provided collateral information along with Mr. A himself. And Mr. A's behavior had noticeably changed in 2023, and I'll get to some of that aspect of the change. As his untreated condition progressed, because in 2023, when they noted this, he was not receiving treatment for anything. His withdrawal and self-absorption became more pronounced. His work performance as well as daily skills declined. So some relevant background. Mr. A had been working for about 10 years as a bagger at a local supermarket. In 2023, it had been noted that he had difficulty concentrating and following through a task at work. Also is the case that residential staff noted there was a change in his follow-through in chores in the household, resulting in Mr. A's noticeable drop in productivity at work. Although he had been working there, as I said, for about 10 years and had always had good work performance reviews, suddenly had a series of events during which he received warnings, and eventually he lost his job following a series of arguments he had with customers at the supermarket. Mr. A's team then referred him to his PCP, with whom Mr. A had been working for some time. So the PCP was very knowledgeable about Mr. A. The PCP did observe a decline in Mr. A, and that observation, combined with reports received from residential staff who shared their observations, led to a diagnosis of mild cognitive impairment. So again, staff report that following the job loss, Mr. A became increasingly sullen, withdrawn, and unresponsive to fellow residents, staff, and family members. He complained of exhaustion, and no interest in social and recreational activities. He had decreased appetite and lost weight. Over the course of the year, he became even more withdrawn and self-absorbed. He was negligent about his own personal hygiene. His activity level had slowed down, and he needed more and more prompting to do even basic tasks, which had easily been within his repertoire of skills earlier. Staff in the group home noted the loss of a long-term staff member with whom Mr. A had been particularly close, and there had been the recent death of several older family members as possible precipitants to changes in mood, but they were really puzzled about his adaptive skills decline. They couldn't quite kind of wrap their mind around that. Treatment and supports. A course of treatment and consultation with caregivers, coupled with antidepressant medications, he was put on Paxil, resulted in a gradual lifting of his mood. And however, even though his mood lifted and there was a minor improvement in his functioning, he remains apathetic, disinterested in activities, and he's been observed as having noticeable episodes of tracking problems. In other words, he misplaces things, he loses track of where he is in the middle of a conversation, and forgetful despite improvement in mood that had been noted. So what do we need to know or want to know about Mr. A? These are some of the questions from the interdisciplinary team. What else should be considered? Is he at a point that there should be a change in his living situation or a change in the type of supports offered to him? What changes can be attributable to depression and what changes can be due to dementia? Note well that Mr. A had not received any cognitive testing prior to his diagnosis of mild cognitive impairment. He still has not received any cognitive testing. The MCI diagnosis was made solely on the basis of collateral report and the in-office visit to the PCP. So the staff has committed to beginning the use of the EDSD, the early detection screen for dementia, but they have not previously used it, and nor had they used any way other than anecdotally to baseline his changes in behavior or adaptive skills. So it also should be noted that he has some chronic health problems, including obstructive sleep apnea. He does use a CPAP. He has mild bilateral hearing loss, cataracts, which are not ripe enough for surgery yet, and is pre-diabetic. So I'm interested in hearing from the hub and certainly from the participants today what your thoughts are regarding, Mr. A and in what directions the team might be considering going.
I saw Dr. Bishop get her hand up first, so we'll start with Kathy.
You can go ahead with Seth first if you'd like. He
No,
tends to
Kathy, go
get to
ahead. No, please,
medication.
ladies,
Okay.
ladies first.
Oh, not a problem. I would really like to go back and look at the grieving that's likely going on of the numerous losses besides possible cognitive and functioning loss, loss of job, loss of network, social network and activities. If this began before COVID and now we've been through COVID, I really think we need to be doing some major work to determine long-term effects of COVID and how we help people adjust back. Because I think for all of us, actually, there have been some significant cognitive decline as a result of 2 years, and maybe many of us experiencing COVID or another one of the underlying conditions related to COVID. But I have found it is that we do not address grieving or recognize the grieving enough. And so I really would want to know his history with the people he's lost, the staff person. Is the staff person at least able to call or do a Zoom, able to stay in contact? Were there specific activities or an interest that they shared? Is there someone else that could substitute? I would really want to look at all of that closely before considering any other changes or moves, but to look for what assistance can come in for him, but also his other peers, because I find when there's one person challenged, there's a lot less time spent with other people. And so there needs to be training for the staff, and there needs to be some really supporting of him and the staff and all that's going on.
Yeah, those are great suggestions.
Yeah, can I add a comment? And I mean, to me, Kathy, you're so dead on, because it really, to me, just imagine that each of us who's lost someone who's saddened by a loss, and is the answer to that loss of grieving giving a so-called happy pill? I'm not saying, I'm being a little rhetorical in my comment. Is that really the answer, that we just get a pill and all of a sudden, oh, I'm not sad by that loss anymore? To me, it's a little naive, is it not? So I really think it is a combination of really grieving, talking through psychotherapy, chatting, those kinds of things, and the usage of an antidepressant or things like that, I think is a crutch or it is a goal. But even if you're going to use the treatment, you might have a partial treatment. So if you're really going to stick to an antidepressant, then you should stick to it and really work it up. 20 milligrams, it can go up to 40 milligrams, whatever. So I really think that's something that really should be looked at. But also, and again, Lucy, the case, this is someone I'm assuming that does not have Down syndrome, right?
No, does not have
Right.
Downs.
Right. So this is a 55-year-old gentleman person without Down syndrome. They have a non-specific mild ID of some sort. So from a genetic risk factor, to think that they're actually going to have dementia, and the issue of using a mild cognitive impairment diagnosis, I absolutely would not like that. I definitely feel that that's, I say, inappropriate, because it's a label. Because really, once you apply an MCI or whatever you want to call it, to me, it's a stereotype. It's a label that you're now applying to the person, and I really think it's inappropriate. I really don't think I would ever use an MCI diagnosis. One, it's speculative, it's not concrete, and it all could be purely related to depression. And I think it's misplaced a little bit to use an MCI, because it does have stereotypic implication that it's the beginning or heralding of maybe what may come on, which might be a dementia. So I really think that was something I would not do. And then the workup is maybe it's obvious depression and grieving, but in the workup and the other comorbidities, Lucy, that you mentioned, is the person being fully treated for sleep apnea? Have they checked their thyroid? Have they checked their B12 level? Those kinds of things. So I really think a thorough workup has to also be done if it hadn't been done already.
Yeah, I've got to tell you, I enjoy facilitating not only because I learn each and every month, but my full-time job is as a professor, and I love having all the hands up in the class, eager to speak. So Catherine, let's please have you join the conversation.
You're on mute.
Catherine, we can't hear you because you're on mute still.
Of course I am. Yeah, Seth just mentioned, I was gonna say, I would want to see some labs done, B12 and folate and D and those sorts of things, as well as, a list of any medications he's on. I don't think we saw our medication list, but a lot of these individuals are on multiple medications. Is there any potential that it could be a polypharmacy issue? Could it be, on multiple anticholinergic medications, which can, cause cognitive, impairment, particularly with long-term use or any other kinds of interactions? I'd want to kind of do a little bit of digging into that. And then Seth just said, and I agree, the cataracts, has his vision declined? I mean, I have early cataracts, and my vision recently, I realized I wasn't seeing as well distances, and I went and had to have my prescription and my glasses changed. And if he can't see clearly, that can be, confusing. Again, hearing loss, or his hearing aids. Has his hearing gotten worse and he needs to have his hearing aids adjusted if he has hearing aids, or does he need them if he doesn't have hearing aids? Is the battery in his hearing aids? There are all sorts of issues that can arise with those sorts of things, and the sleep apnea. So yeah, I think there are a lot of contributing factors here that could be delved into a little bit further before we conclude that, this is MCI. And I just want to echo on what Dr. Keller said about the diagnosis of MCI. As soon as you give that to someone, you've labeled them, and it's just kind of a blurry thing to say to someone, particularly in the absence of having ruled out any of these multitude of other things that can, potentially cause those symptoms that look like the onset of dementia, but might be potentially treatable.
Thank you. Lucy, yes, let's hear more.
Yeah, so before listening, if anybody among our participants might have some thoughts about this, I appreciate the comments of the Hub team, and just want to point out that there were some changes prior to his loss of job, and actually leading up to his loss of job. And so it would be interesting, and I think a comprehensive assessment is the way to go. Not only looking at all kind of, in terms of health systems, but also mental health, that what was going on there, and it could have been COVID related, and it could have been that he was depressed or anxious about other things. And it could be that we're not ruling out the fact that this may be prodromal or a harbinger of dementia, because that is a possibility as well. My personal experience is that nobody uses the mild cognitive impairment diagnosis for our population, but I basically just threw it in there because I didn't want, to kind of give him this. It would be more likely the scenario that he would have been diagnosed as having dementia. And that on the basis of no testing, so on a basis of collateral. So, going back to something that Dr. Bishop often talks about, which is the necessity for differential diagnosis, and our understanding the complexity of people who present to us, and all the many factors that might be contributing to what we see as an observed change or decline in functioning in any area. So I just just wanted to throw that into the mix, and really curious to know if anybody in our among our participants have any thoughts, or does this resonate in any way to people whom they support? We resonate with them. Mm-hmm.
Lucy, can I just add one additional comment on diagnoses? I mean, there's no doubt. I mean, here we are, echo, dementia. I mean, certainly dementia is certainly a possibility, but again, it's very early in this person's life, unless they have Down syndrome, early onset. But certainly, can you really exclude that, as you're mentioning, the beginning of a quite quote unquote dementing illness? And in most cases, a dementing illness is a neurodegenerative disorder in the vast
Right.
majority of people. And a neurodegeneration is a breakdown of the connections of the nervous system, the axon, the neurons. And the number one type of a neurodegenerative disorder is Alzheimer's dementia. And I'm bringing this up because, in terms of the testing, we can do assessments which are important for a qualified way of assessing their level of functioning or memory dysfunction. That's what these assessment tools do for memory and what have you. But there are now the beginning of what are called biomarkers. And a biomarker, and I just want to bring this up because you were talking about testing. So a biomarker is the biological measurement of the condition which you're looking to find if they have. So if you think they've got thyroid, blood test. You think you have vitamin level, blood test. If you think you've got Alzheimer's, they're scanned. They're actually imaging and measurement of the protein that is accumulated in the brain called amyloid. So if you want to know and you really are suspicious of a dementia or a neurodegenerative disorder that is the number one cause of dementia, Alzheimer's, there are these tests. So people now, and this is what I do every day, I make the decision. Do I think they've got a dementing illness? And if I do, it's aside from B12, folate, sleep apnea, hearing, vision, all that kind of thing. I'm also looking at the ability for me to do a brain imaging, not only an MRI to look for the generality of what the brain looks like, but I'm looking for the accumulation of amyloid protein by measuring, it's called a PET scan. And this will also depend on their health insurance. So in the United States, it's Medicare predominant. So if you have a Medicare beneficiary, often PET scans are covered. So I have to put in an Alzheimer diagnosis, Medicare beneficiary, and I can get it. And also I do ApoE. I'm now doing ApoE blood tests to see if they genetic predisposition that's somewhat higher in the Alzheimer population of ApoE positive patients. And I do that. So I've changed in the last year. I've actually myself as a neurologist are now doing more, because before it was almost like an ambivalence. I hate to say, almost like an ambivalence. Do I think they got Alzheimer's? It's going to be Alzheimer's. There's nothing I do about it. But now with this new therapeutics that are coming out in the market, anti-amyloid IV medications, there's something proactively I can do about giving the right diagnosis. Maybe there's a therapeutic for them. So I've actually evolved and changed in my own practice.
That's great to hear. Yeah. Dr. Bishop, please.
Sure, and I gladly waive if there's someone participant that would like to add, but since I don't see anyone, one of my biggest concerns is that most community providers, and Seth, you're a neurologist with experience with this, so you are a rare exception. Most do not understand basic baseline functioning. And too often they compare the functioning of an individual that they're seeing with IDD to the general population and assume that functioning is related to some kind of loss, because there appears to that healthcare provider to be a reduction. I don't think we address that enough. And I think there needs to be, in med school for healthcare providers, really needs to be understanding how different the baseline is. And you cannot make any assumptions based on one or two visits until you get that background history and baseline functioning, or you begin with baseline functioning then. And I think that's one of the most important things with all of our discussion. We need to make sure is one of the bases that we need to advocate for.
Right, absolutely. Yeah, we need to know where they're coming from. Where were they like before? Because
Yes.
yeah, it's all relative, right? From where but what were we like, all of us like when we were younger to now? And in your ADLs, your activity daily living, your functionality, your activities, and how well did you perform them? It's all relative. How well were we successful in performing it? And that's the same thing with people with developmental disabilities, is what did they do before? It's all relative. maybe they needed a little support or more, and that was their best performance. But what does that change from then till now? And that's why the EDSD and other scoring systems should be looked at from before, like an IEP or some other kind of metrics that a lot of our population has gotten when they're younger, some kind of measurement of some functionality as a baseline or a life story that we all talk about.
Yeah, well, in the case that I presented to you, so there were clear changes from baseline functioning. So for instance, in work, however, that wasn't followed up with immediately. So if you have somebody that has a 10-year history of doing something and has consistently gotten good work performance reviews, people don't randomly change in terms of their ability to kind of sustain something. And so what was going on, there didn't seem to be enough of in what I'm suggesting in this case, there wasn't enough of a timely curiosity about how is it that this gentleman is now performing in a very different way at work, which was a very important part of his work, his week. He spent a lot of time on a job and had people whom he connected up with. I didn't tell you that, but he connected, that was part of his social support network, that he had people at, the supermarket whom he had contact with on a regular basis. So there's a lot of things that were going on around that, and that, maybe we begin to get curious a lot sooner about these things and begin asking all those good questions that members of the hub team have brought up.
I want to say thank you for this conversation, because as I listen, I'll summarize and say that we all too often, I think, as providers or caregivers, wear that hat as our identity in relationship. And perhaps that conjures up initially the protocol that we might have learned in school or training on what to do in this scenario when, for example, here, dementia is suspected. But the reminder is always to keep at the forefront the essence of the person, if I can borrow from Dr. Bishop. And as their friend, as their provider, as their family member, we are their advocate. And we can have the lens, not only the hat of the provider, but the lens of a fellow human being who could put ourselves in sympathy or empathy with the person and realize, if that were me, man, I would be really sad, perhaps grieving at this loss. So yeah, thanks for helping me put myself more in the shoes of the person in your case. Catherine, I guess I'll let you kind of close us out and tell us a bit about the QR code that you have on the screen for us. Maybe also on your screen, hit the display settings. We can see your shared screen, I guess I should say, in presenter mode.
Yes, I was attempting not to touch anything for fear I was going to
Oh,
do
yeah, we
something
can still
desperate
scan.
to it in some way and make it disappear. So it is in presenter mode, but I think it's big enough that everybody can see it. If you would all take a moment, our funding for this comes from the Texas Council for Developmental Disabilities through the University of Texas and Houston Health Science Centers. And they have a very brief survey. They would appreciate it if you would fill out for them. It'll only take you a couple of minutes, and we would be very grateful if you would do it, as will they. So if you could take out your little smartphones and just click on that QR code, it'll take you to an online survey that will take, just a couple of minutes to complete. And so we thank you for doing that. I'll turn it back to you, Cameron.
Thank you. I've been encouraged by this month's session, as I am each month. I wanted to point out that we had at its peak, I think 20 or more members gathered for this project Echo Topic. So Dr. Ezralou, I want to thank you for having a timely topic that advertised in our email, brought a slew of folks from Texas to learn together, to teach together. Thank you, Catherine, for being our organizer, recruiting both our didactic speaker and case presenter each month. If you, one of our spoke sites out in Texas have a case to share or a special request for a didactic lesson, we're always open to those as well. And we'll sign off for May and look forward to see you at our next Project Echo. So thank you, everybody.
Thank you, folks. Bye, everybody.
Goodbye.